Good afternoon, Wendy. It's great to see you. You're still muted, but that's fine.
There
It's
we go. How are you?
I'm very well. Yeah, and it's really great to have you. So can't wait to hear what you're going to tell us, all the practical and great things.
Well, yeah, I hope it's useful. I think that follicular lymphoma is certainly a challenge, isn't it, clinically? So I hope it's useful.
Definitely. I think you just have much more weapons to attack it with than we have. Well, in public service, as you know, as we discussed before. It'll be nice to see if there's some private colleagues from private, because they will have a different experience.
Yeah, exactly. And I think that even I think we're still sort of quite frustrated. So I only do public work in the UK, and whereas we've had a lot of large cell options reimbursed, there's still we still are waiting to try and get some of the newer treatment options reimbursed. So so there's not as much available, certainly for follicular in the UK, as there is for large cell lymphoma, which is frustrating. But I think it will be good to discuss, how we are all doing things differently.
Yeah, no, that's true. We hope we get a few clinical trials. That'll also be great for the patients to have access that way. So I see, we always start a little after 4. So I think, we can just relax a bit. I'll put off my so that's the only thing. I'm just trying to see if I think let me actually see. Here's the slides, because
and I've got them open as well from
okay, so
the
you've
ones
got
that I've sent, so I should be able to. I was going to check I could share them okay, and then as we discussed, I was going to stop after first line for any discussion, and then do the relapsed refractory, if that still works for you. Okay,
that's perfect, and then we can talk a little bit of the collaborative work. I see. Remember, I actually, so it's easy for you to share. You're fine.
does that work okay if I just go from the
perfect? That's awesome. So you can unshare then. You are quick.
Okay, so you can see that. Okay, yeah.
And no, that's fantastic. Let's see if I can be that quick, because I must start with the housekeeping slides. I'm sure I'm also capable of doing that. Am I not? Let's see. Okay, but now I must just go to there you are. Okay, good. So, okay. So I can perhaps leave it at this. Then it's your topic. That's perfect. And then we can just, mute and close the cameras for a bit, and then let everybody
and then
come
ready to go in a few minutes. I always like to come in early just to check that my technology is working okay.
Exactly.
I'll mute and stop for a few minutes, and then
and we look forward to not only the science, but also really having a nice, time with you. So good. Okay.
Ja.
Miskien wil ek dink sy het amper gesê hulle vertrek môre soos dokter net van oor haar uitslaag kan werk.
Wendy, I see I, for some reason, have your name too.
Oh.
I think it's because the link came up that way.
Oh, I see.
My old link didn't work. So I will keep on my, well, turn it off, but there's 2 Wendy's this afternoon. Yeah, so this is about the time we typically start. So let me share my, my slides. And yeah, it's great. There's already quite a lot of people on this, the very last session of the year. So let's get going. Good. Okay. So a very good afternoon from Cape Town to the rest of Sub-Saharan Africa, to South Africans and beyond. It's great to have you with us this afternoon, and this is the last session of the year. And Dr. Wendy Osborne will be our speaker. She is no stranger to us. She was part of the most excellent lineup we had at the Hem-Onc meeting that was September this year. And now she's beamed over to us, courtesy of Roche. So just a few housekeeping notes from our side. The recordings are still on the website.
Hi, it's Dr. Gottrell.
Oh, Kevin, you're, oh, perfect. Great to have you here, Kevin. We really appreciate you always. And today is a topic that's near to your heart too, I know. So we are reorganizing the videos on the Blood SA website, trying to make them easier to find in different search functions. So watch that space for next year. Please remember to put some comments and questions in the chat box. Always very nice for the speaker to be able to get back to that. And it's easy that we don't forget what we wanted to ask. So today, Dr. Osborne will be speaking in sort of 3 sets of slides, and there's going to be lots of time to speak to her. And she is very practical, very up to the minute. So then things regarding the mailing list or CPD. Melanie Davids is our secretary. And please remember to complete the anonymous feedback survey at the end of the Zoom meeting. So here we are. Khadine, who put up most of the meetings, and now we have Dr. Bridget helping her. And then the agenda for today is follicular lymphoma management, yesterday, today, and future treatment. And so it's a really lovely topic, and a very interesting disease that we perhaps haven't quite found the final answer to. And I think on both sides of the continents, lots of questions regarding reimbursement and what the best treatment is. So without more ado, let me just present Dr. Wendy Osborne to those who do not know her. So she's a consultant hematologist at Freeman Hospital in Newcastle upon Tyne Hospitals Foundation Trust. First class honors in her class in 1998. And she had qualified, I suppose that's the north, Wendy, is that not? Sort of the north of England.
That's right.
Was hopped over a bit to Scotland, and then back in Newcastle. That is still in northern England, isn't that?
That's right. We're quite close to the Scottish border, but we're still English.
Okay. So she's a past chair of the British Society of Hematology Lymphoma Special Interest Group, and she, together with the National Cancer Research Institute, I think that's what it is, the clinical studies group, she works in all of the lymphoma subgroups with all the colleagues across the UK, and we're quite interested to hear a bit more about that. We think that is the way to go. Just like clinical trials are for patients we don't know what to do with, so registries and collaboration is for knowing even more about our patients, isn't it? So we really, really look forward to everything you have to tell us this afternoon. And yeah, so it's over to you.
Thank you very much. And yeah, I'm delighted. I wish I was back with you in person, partly because you have such a beautiful country and partly because it's a lot warmer than it is in freezing England at the moment. But really, I think, as you said, I'm just going to get my slides from the beginning. There we go. Is relapsed, well, follicular lymphoma in itself, I think, is such a difficult lymphoma because it is so heterogeneous with so many different disease factors which vary much more between patient than, for example, large cell lymphoma, and also patient-specific factors. And so this is therefore something really important that we discuss in our MDT each week. And there isn't such a fixed pathway as there is for large cell lymphoma or even Hodgkin lymphoma. So what I thought I'd do is maybe spend 20 minutes or so talking about first line management, and then I'll stop screen sharing and maybe we can have a chat and discuss a couple of the points that came up about that. Then I'll be talking about relapsed refractory again for another 20-25 minutes or so, and then we'll discuss the questions with relation to that, and then finish on about this collaborative working, which is something that there are some good things I think we do in the UK and some things in which we could improve. Here are my disclosures, and here is a disclaimer from Roche. So follicular lymphoma is important, and it's important because it's common. It's the commonest indolent non-Hodgkin lymphoma, but it's also important because there is a variety of different approaches to managing this lymphoma. And with this lymphoma in particular, I think that our communication with our patients is so important because not only is it talking about careful discussion about when a patient needs treatment, it's also that important reassurance to a significant number of patients who never need treatment, in whom, if we don't do that right, patients with cancer never needing treatment actually can have a big impact on their emotional well-being throughout their life, despite having no physical need for treatment. So it's important because it's a common lymphoma, but it's also important that we're explaining carefully to our patients. It's pretty rare to see CNS lymphoma involvement or mediastinal involvement, but we do quite commonly see bone marrow involvement with this lymphoma. And so I think really that this is why follicular lymphoma is important. We don't have this fixed standard of care. The choice of treatment that you make second or third line will depend on what you've chosen first line. And for the majority of our patients, we aren't able to cure them. So it's different in terms of our approaches and the decision about what toxicities you might be willing to expose your patient to, depending on the aim of that treatment in a usually incurable disease. And then I think risk stratification is something that we still have a lot to learn about. We have a lot of prognostic scores in follicular lymphoma, but they don't really guide treatment, and none of them are as prognostic as a patient who relapses early. And the most prognostic feature that we know about for follicular lymphoma are those early relapses. I'm going to talk about those, but that's a little bit late. That's late. It doesn't help us with those first line treatment decisions. If we know a patient later goes on and relapses. So that's still something that is a huge unmet need. So these are the 4 questions that when I see a patient in clinic that I'm really considering. I think that we all know that there's a watch and wait group of patients, so patients who don't need any treatment. And is this something that we should do for some people? If our patients need treatment, how do we decide upon chemotherapy backbone and which antibody partners should we use, either rituximab or obinutuzumab? There is a discussion about whether we should be giving maintenance to our patients. And again, I think there are pros and cons of maintenance. And then a little bit about the evidence for a so-called chemo-free approach. So R squared, rituximab lenalidomide. I don't like the term chemo-free because that sounds as if it should be toxicity-free. And we all know it isn't without toxicity, but it is a different approach to our patients. So if we have a patient with follicular lymphoma, the decision about treatment versus watch and wait depends on, I think, these 4 things. Stage is very important because for some early stage patients, we can still cure some with radiotherapy alone. And therefore, I do think it's an opportunity not to be missed to try and cure a subset of patients. So therefore, understanding who the early stage patients are and what sort of baseline imaging we should do for those patients is helpful. For the more advanced stage patients, we have criteria as to whether they do need treatment, and I'll talk about those criteria, but also if the patient has symptoms. So a patient who has got drenching sweats, significant weight loss, we would be wanting to give those patients treatment, unlike an asymptomatic advanced patient. And with all of these discussions, the patient opinion is essential and shared decision-making. So early stage disease is about 1/5 of patients. And we know that if we stage them with a PET scan, it's more accurate. And it makes sense that actually the outcomes are better for stage 1 compared to stage 2 disease. So I normally would stage most of my patients with follicular with a CT scan. That's partly so that we can save our PET scanning resources for lymphomas where it's certainly making more treatment-related decisions, such as Hodgkin lymphoma or end-of-treatment large cell lymphoma. But for our follicular patients who on CT staging look like they have only early stage disease, I will go on and do a PET scan purely to allow our clinical oncology colleagues to identify the accurate field of radiotherapy, aiming for curative intent. And this is a group of patients in whom we will give 24-gray curative intent treatment. And for those patients who are stage 1, then I would hope that we would cure 74% of these patients, maybe slightly less. If I didn't have access to PET scanning, then personally, I would probably still, as we always used to, just trust the CT scan and still give that radiotherapy on CT guided staging with the hope that I would still cure a significant proportion, albeit missing maybe slightly more advanced areas of diseases that weren't identifiable on CT. If they have advanced stage disease, I think it's these 2 things, symptoms, but also the staging on CT. Because if my patient has got quite significant bulky disease, or if I'm concerned about imminent organ compression, so if you see that they've got a bit of hydronephrosis and they're going to start obstructing their kidneys, that for me would be an indication to treat. So occasionally a patient with advanced, even if asymptomatic disease, but they met any of these criteria, then I still would want to treat. These are some of the prognostic scores we have available. I have to say, I don't usually do them because it doesn't really make a difference in terms of my treatment decisions. My treatment decisions are based on symptoms and on staging, as I've said, in terms of whether it's stage 1 and I'm going to give radiotherapy, or advanced stage and concern about imminent organ compression. I'm hoping that in the future, we'll be able to understand the biology better, that we'll be able to understand up front those patients who are going to go on and, for example, progress early needing treatment. Now, we have a lot of discussion about the groups of patients in whom they don't have symptoms and they don't have these disease sites where we need to start treatment, but we think about whether we're going to do watch and wait or active surveillance. Because we know that for some patients, they are never going to need treatment. But we also know from this watch and wait study that patients, if they are given rituximab alone, it will delay their time to their next chemoimmunotherapy. So the watch and wait study included all asymptomatic patients without any Guelph criteria of requiring treatment, and they were randomized to either watch and wait, so clinical surveillance, something called R induction, which was 4 doses of rituximab given weekly, so once a week for 4 weeks, or the R induction followed by maintenance. And at 3-year follow-up, it showed that the patients who were just on the watch and wait arm, half of them did need treatment within the 3 years. And it was much less in the rituximab induction arm at 22%, and even lower in the patients who got 4 doses of rituximab and then 2 years of R maintenance. This study also showed that patients who had treatment had an emotional well-being improvement on their patient-reported outcome measures. And so this comes back to my point that if you're telling someone they've got cancer and then you're not doing anything about it, which is the complete opposite of what you read in the newspapers and see on the news, that causes a lot of anxiety for patients if we're not explaining carefully about why we aren't treating them, explaining that a significant number of patients won't need any treatment. It was because of these data that NICE approved just the R induction, so 4 doses of rituximab. So I am allowed, and it's reimbursed in the UK, to give 4 doses of rituximab for patients who have got advanced staged asymptomatic follicular lymphoma. But interestingly, this wasn't based on a clinical need. It was based on a health economic need, in the sense that because of the age of the population, if patients are given those 4 doses, for some of them, it will delay the time to next chemoimmunotherapy. And during that time of delay, many patients, because of the age, will have died from other causes, and therefore you're saving costs to the NHS of that additional chemotherapy. So on a health economic basis, that was approved, but it isn't without side effects of giving everybody rituximab. So on an individual basis, I certainly don't use that approach for many patients. And I want to just show you the additional follow-up data now that we've got 13 years follow-up from the watch and wait study. So this showed that if you had rituximab induction, so this was the group I'm most interested in because that's funded in the UK, so 4 doses of rituximab, patients didn't need treatment for 10 years on average. However, and that was compared to 3 years if you had a watch and wait approach. So if you have a patient in front of you that you know is going to need chemoimmunotherapy, you are pushing that time to treatment from 3 years with watch and wait up to 10 years if you give them rituximab induction. And this is for particularly older patients, might be quite helpful that they may never need to have rituximab chemotherapy. But I think the really important thing is also to note that 30% of patients never required any treatment. And so there'll be 30% of patients in whom you are giving this rituximab possibly when they didn't need any treatment at all. And 12% of patients had spontaneous disease progression. And also there was no time to the second R chemo treatment. So although it might push back the first treatment, it doesn't do a similar thing. They all had treatment if they needed a second R chemo at the same time. So this is something I discuss with patients, but I have to say that in view of 30%, so nearly 1 in 3 never needing any treatment, and my worry about giving immune suppression, particularly as we come out of a pandemic, my worry about giving immune suppression to everybody means that I don't do it for many patients. If I have somebody who is maybe very old and I might not think they could tolerate chemoimmunotherapy within a few years, and there are certain features when I'm slightly worried that they might be in the group I'm going to go on and treat, or if I have this really hyper anxious patient that, despite me being able to try and explain about this fact that 1 in 3 will never need any treatment, and For those patients, I sometimes do give rituximab alone, 1 dose for 4 cycles. Now, I do just want to very quickly mention this discussion that giving rituximab reduces your risk of high-grade transformation, which in the watch and wait setting, I don't believe is true. But this came from the Aristotle study. And the Aristotle study was essentially looking back at over, well, initially 10,000 patients, looking to see if they have had rituximab, does it reduce the risk of high-grade transformation? Now, the important thing about the Aristotle study is that it didn't include these asymptomatic watch and wait patients that I'm describing. It's actually patients who needed rituximab with chemotherapy because of the need for treatment. There were a few patients who were included initially on a watch and wait period, but only if they'd started systemic treatment within a few months of the study. So the patient grouping, you cannot extrapolate this Aristotle data to this data for our watch and wait patients. So, and I'll just show you a bit more in detail, but already if you look at the patients they looked at for eligibility, and they had identified 5,000 patients who had progression or relapse, the majority of these were not rebiopsied. So trying to talk about high-grade transformation when actually only 1,000 out of the 5,000 patients were rebiopsied and small numbers had histological transformation, that in itself does lead to some questions about some of these inferences from the data. And then, as I said, only 14% out of all of these patients were on a watch and wait approach. So it's me that even though they concluded that the patients who had rituximab had a lower risk of transformation to high-grade disease, these were patients who had rituximab as part of our chemo, and this wasn't patients on a watch and wait approach. So should I watch and wait? If your patient has early stage disease, personally, I would choose to give them curative intent radiotherapy of 24 Gray. While I'm talking about radiotherapy, we often give a very low dose radiotherapy, so 4 Gray, the so-called FORT approach of 2 doses, 2 fractions of 2 Gray, because for those patients you're not trying to cure, but just control that disease in maybe a particular site that's symptomatic, that does hold the patient in some situations for many years. So we would tend to use just the low-grade approach unless it was this isolated early stage patient who would have the 24 Gray. Then for the other patients, if they're asymptomatic without disease criteria needing treatment, for me, I would watch and wait the majority of them, but there's an occasional one in whom either because of anxiety of the patient or maybe age and frailty of the patient, and I really don't think they're going to tolerate chemoimmunotherapy, that I may consider giving single 4 doses 1 week apart of the rituximab. So even before we've started, I think that that's also quite a heterogeneous group of patients. But then if we have decided to treat, how do we decide upon the first-line chemotherapy and which antibody backbone? So we've got a few studies that have compared chemo backbones. The Follow-5 study showed us that R-CHOP was better than R-CVP. And so I think that's quite helpful to know that CVP, although efficacious and much less toxic than R-CHOP, it will mean that your patient will have a shorter progression-free survival. And then when the bendamustine data were compared to CHOP data, there was no maintenance given with bendamustine. It showed that there was an improvement in progression-free survival in the patients that had bendamustine. And the bendamustine data in the BRIGHT study also showed that it was non-inferior to CHOP or CVP, with a trend towards improvement of progression-free survival. And I think really when we saw that the STILL data published, this is when we moved to a bendamustine as our frequent chemotherapy backbone. And I certainly try to say the anthracycline approach of CHOP for my high-grade patients. Although many centres would use CHOP as a chemo backbone for follicular, I tend to choose either bendamustine for the longest progression-free survival or CVP if I want to have less toxicity for the patient. If I'm using bendamustine, we know that causes prolonged T-cell depletion for up to 2 years. And I am very aggressive with my antibiotic prophylaxis. And I make sure my patients have acyclovir and cotrimoxazole prophylaxis for 2 years from the end of the bendamustine. The gallium study did not look at chemotherapy backbone, that was physician choice, but it did randomize patients to given either obinutuzumab or rituximab. And the gallium randomized data showed that there was a progression-free survival benefit of about 8%, but no overall survival benefit for the patients who had obinutuzumab. There was a slight increased risk of infections with obinutuzumab and slight increased risk of infusion-related reactions with obinutuzumab. So if I'm thinking about chemotherapy backbone, then I look at patient fitness. And if they're fit, so and usually under the age of 70, I give Benda. If they're older, and Benda is tough, and I'm not aiming for cure for these patients, so I don't want the toxicity, then I tend to give CVP. And then I talk to the patients about the pros and cons of obinutuzumab in improvement in time to next treatment compared to rituximab, which we can also has less infusion-related reactions. And also maintenance, we give subcut maintenance for rituximab, whereas we still have to give intravenous maintenance for obinutuzumab. Now, should we give maintenance? And I think that when we think about maintenance, I definitely am very biased with my outcome measures in terms of I always am thinking about progression-free survival, time to next treatment, event-free survival, trying to look at efficacy-related outcome measures. But the more and more I discuss this with my patients, what they're always asking me is, how many times will I have to come to the doctor? Will this stop me going away on holiday? Will I need to be admitted to hospital with this? And therefore, again, what I'm learning is that the outcome measures for the patient is something that we really do need to consider. And so if we're thinking about maintenance, yes, it does improve time to next treatment and progression-free survival. We've now got good follow-up from the PRIMA study, and you can see that PFS benefit is maintained, but there has been no overall survival benefit. So therefore, I do talk to my patients, and I've had, younger people who want to go around the world on a trip. They don't want that ruined by having to come up to the hospital every 2 months for maintenance. And so for those patients, they choose not to have maintenance. Whereas for other patients, that time to next treatment is most important and they will come up. We did pause maintenance on our patients and stopped it on quite a lot during the pandemic because we felt that the risk of coming to the hospital for the maintenance injections was higher in terms of risk of exposure to COVID-19 when our patients were all shielding than actually the benefit of increasing that time to next treatment. And so, although because we clearly don't have any overall survival benefit, I do talk to my patients. I would say on average, most of my patients do elect to have the maintenance. I have a low threshold to stop. So if they have a hospital admission due to infection, or if they have neutropenia due to the maintenance, then I would just be quite keen to stop because it's about balancing that risk versus benefit of the maintenance. We know that obinutuzumab maintenance has this superior PFS, as I showed you, and with additional follow-up, that's been maintained. A big question at the moment is, can we use PET scanning and MRD to guide maintenance? So if a patient is in a PET complete metabolic remission at the end of their chemoimmunotherapy, Do they still benefit from maintenance? And the FOL12 study looked at that question and also looked at the MRD negativity. Now, MRD is not something that can be done in a clinical trial. Sorry, can be done in real life, only in a clinical trial. But PET scanning can be done as a standard of care. As I've said to you, when we have, although we're very lucky and can access PET scans, we don't have unlimited access to PET scans. And if I need to be using and accessing our PET department, I really want to be making sure that it's going to impact on my treatment decisions. So at end of treatment, it doesn't usually change whether I'm going to be doing maintenance or not. And I'm going to show you the data behind that. We know that if somebody after follicular lymphoma chemoimmunotherapy, if they obtain a PET negative complete metabolic response, they have an improvement in their overall survival. So Judith Trotman has published that data from the Gallium study. So it is prognostic, but it doesn't change my treatment. So I don't always use up PET resources by doing them. But in this study, they looked at patients, and if they got a PET CR, they randomized patients to look and see, should they get maintenance or not? If they were just in a PR, they escalated them to Zevalin. That's not something we've got access to. But I think that this is quite interesting because it showed that even if patients have got a PET CR, so if you look at the top two sort of orange boxes, you've got an end of treatment PET negative and an end of treatment PET positive. So the patients in arm A, which is the blue curve, had the maintenance, and the patients in the red curve had a response adapted approach. So even if patients are in a PET negative CR, they still appear to get that PFS benefit from the maintenance. So PET guided approach alone to maintenance isn't the answer. And it appeared similarly true for the MRD as well. So maybe it's just that we haven't got the accurate level of MRD yet. So at present, I have a discussion with patients about maintenance or not, and that isn't based on their end of treatment PET scan. The FOL12 also shows us that you do still get PFS benefit after maintenance with bendamustine. Just to finish up our first line discussion, I've talked about chemo backbones, I've talked about antibody and antibody maintenance. What about first line rituximab lenalidomide? And this came from the relevant study where patients were randomized to R squared or R chemo. Now, I think there was an expectation that this might show superiority. It was actually designed as a non-inferiority design, and it did show that R squared was non-inferior. So the way that the statistical design was, it's not shown superiority, and I think that it was so similar the outcome that even if they had a different design, I think that it's equivalence, not superior. But because of that, R squared now has a licensed first line. In the UK, we only have that license in a relapsed refractory setting, which I'm going to talk about. But it is certainly in the US, a lot of people do use that approach of R squared instead of R chemo. So when we're thinking about first line treatment, I think that it's really important for the early stage patients to be considered for radiotherapy so that you hopefully will cure some and they'll never need to go on and have chemo antibody treatment. I think the key to me for watch and wait is clear communication with the patient so that they're not on a watch and worry approach. Yes, 4 doses of rituximab is an option. And yes, for some people, that will delay the time to next treatment. But 30% of people will never need any treatment. And I have to say, personally, if it was me, I would probably avoid being exposed to rituximab and hope that I was in that 30% that would never need treatment. Low dose radiotherapy for sites of symptomatic disease is helpful to try and again delay any chemoimmunotherapy requirements. And I think that with no survival benefit, individual choice of chemotherapy is important, and we make chemotherapy choices individually, and then antibody partner choice individually, depending on patient factors and discussion with patient factors. And for some people, they can access R² in a first-line setting. So I'm going to just stop sharing there in case anyone has any questions before I talk about relapsed refractory lymphoma, because you'll be sick of my voice continuously if you have it for an hour and a half without any discussion. So if anyone has anything they want to ask, and put it in the chat, or just put your camera on and ask, whatever works best, I don't mind.
I, for one, have a few questions. I'm sure some of my colleagues also would like to ask something. I don't know. Jacques, Vernon, Fatima. It would be great to hear if any of you have questions. I think from my side, I actually have a question about your R², but let me just first start at this watch and wait and the stage 1 and 2. As a question, even when I worked in Europe, we didn't see it that often. So it seems that in the UK, you see this early stage disease more often. Or we don't have, or we've never had strong enough nerves, you know, because I see you said I think not more than 3 centimeters, not more than 3 sites with, or less than 3 sites with at least 3 centimeters, or less. I think that there was quite a lot of criteria, and then no one lesion could be more than 7 centimeters. So I'm just interested, where do you typically see your stage 1 disease or the stage 2? Because if I now think back, I can think of people with actually inguinal lymphadenopathy stage 1. But where do you see it? And I would love to know if my colleagues have other opinions or see other things.
So most typically we tend to see it in neck nodes and supraclavicular nodes, and we have quite commonly, I would say, you know, at least a couple of times a month in our MDT, we have an early stage patient, because we'll always say, okay, let's do a PET to confirm it's early stage disease. Occasionally we've had some that is an inguinal node, and I think that's even easier to be keen to go in with higher dose, well, treatment dose radiotherapy of 24 Gray, because of the less concern about toxicity in inguinal nodes. I think you've really highlighted an important point about not only there being heterogeneity in the disease, geographically it is so heterogeneous, because, for example, you know, in Saudi Arabia, they hardly see anybody with follicular lymphoma, and in the Middle East. And so there is such a variation in this lymphoma, which is why I think it's so fascinating what the true etiology is, in how even in incidence of this disease. So it is very, very rare in some parts of the world, and in some parts, obviously in the UK, we see early stage more commonly. I think that your point about advanced stage, so if I see somebody with clear bulk, so more than 7 centimeters, yes, that would make me choose to treat. We definitely are not as strict with our criteria in terms of looking at tumor volume. So if somebody has, you know, even if they had 4 or 5 areas of measuring 3 centimeters, but they were asymptomatic, we still wouldn't say, okay, we need to treat. So as soon as they've got symptoms, that will be triggering us to want to treat. But really, when we look at their scans, if we just feel that there's risk of progression or site of progression, then we would treat. I don't routinely do imaging, but there's been the occasional patient who's been a bit borderline. Shall we actually repeat the scan in 6 to 9 months to make sure that we don't think that there's organs at risk?
I see Prof. Lowe has a nice question. I don't know, do you want to ask it yourself, Vernon, or shall I read it? You speak of the good results with BTK inhibitors. Great.
Hello, Wendy. Very nice to see you.
Nice to see you too.
Superb talk so far. Yeah, so my question is actually a very simple one. Single agent BTK inhibition for these patients, we would traditionally have taken a watch and wait approach. Are there any trials ongoing or foreseen to happen in the near future? I would imagine so, but I'd love to hear from you. Thank you.
Yeah. So I think that with patients including in a watch and wait approach, now certainly the ones that we are looking at have not been, because of the fact that 30% of people never need treatment, bringing in a treatment arm is something that many sites are quite reluctant to do unless it's single agent antibody. I think that some of the BTK inhibitor, certainly some of the data look encouraging in a relapsed refractory setting. We don't have a trial open at the moment, and it's which way a huge amount of our trial portfolio is moving into the T-cell engagers rather than BTK inhibitors. I think that when we talk about relapsed refractory disease, then I think that there's certainly the focus is moving. We had a huge focus on PI3 kinase inhibitor pathways for a long time with our research, and now because of toxicity concerns, that's moved away. So I am not sure which way BTKI is going to go in follicular lymphoma. We're looking at it more and more in CNS lymphoma, for example. We've got a relapsed refractory CNS lymphoma with zanubrutinib open, and I think it's going to be really interesting. But what I hope is once we understand the true biology, because it's not just one disease, that we'll be able to target different pathways for different subtypes of follicular lymphoma. That's where I see the future.
Thank you.
One more question from Augustine Adu. I must say, my very talented radiation oncologist colleague still uses chlorambucil with some good effect. Does it ever happen in I suppose with, like CLL, you may use it with rituximab, I would guess.
So exactly right. So I think there is still a place for chlorambucil, and certainly for my less fit older patients that I'm not even keen for CVP, then I use our chlorambucil. And I think that it's about trying to get that balance between time to next treatment versus toxicity of treatment. And there is no survival, as is pointed out in the question, there is no survival difference in any of these treatments. And so when I speak to patients, the biggest thing for many of them, they do want that longest response at this time point. So they do want that longest response. But if by giving them the chemo backbone that should give you that longest response means that they're in hospital for several admissions with sepsis, you've lost the benefit of trying to obtain that longest response because they have so much toxicity. So there is certainly some patients that I've given chlorambucil to. I also think that there's some intriguing data, but I'm not convinced by it yet but I want to see more of it. In the gallium study, they looked at MRD, and what they showed was that you appeared to get a deeper MRD response in the CVP patients given obinutuzumab than the CVP patients given with rituximab, more so than with the stronger chemo backbone, the Bender backbone. And some people arguing that giving this stronger antibody with the weaker chemo brought down that MRD response. The reasons at the moment that I'm not convinced, and that isn't my decision to give, if I give CVP, should I definitely give O with it? The reason that I don't is that the chemo backbone arms were not randomized. It was physician choice. And the numbers of patients that got CVP in the gallium study compared to Bender or CHOP are still small. So it's not powered to answer that question, but that is certainly something that, so I've heard some people say, well, I'm giving CVP, so I want to give obinutuzumab with it because of that MRD data. So my interpretation is slightly different, but I think that signal may or may not be there, but the data aren't there at the moment. But if the worst thing to do is to give a chemo backbone, such as bender or chop, because you want the longest time to next treatment, but then you've given so much toxicity to the patient that they've ended up having either anthracycline toxicity or significant sepsis. And you're right, if you're not getting a survival benefit anyway, what should you be doing? So all of these factors have to be taken into account. And if somebody's borderline fit, I would drop down to CVP and not give bender, or drop down to chlorambucil and not give CVP.
Great. I actually would love to know something about R squared versus R bender, but I think we must probably move on to the advanced. That may come up again or not. I don't know. You're probably
So
going to.
I'll be talking about R squared in a relapsed refractory setting. So
Okay, great.
So I'll make sure. Great. So here I am. Good. Can you, oh, now have I gone on to mute? There we go. Can you see that?
Good.
Can you see that okay?
Yes, looks great.
Yes. Perfect. Good. So we've talked about first line, and then I think that relapsed refractory can cause even more discussion in our MDT. We know that if patients have a response, usually each remission is slightly shorter than the one before. And that's certainly the pattern that I discuss to patients when we're talking about chemo choices. However, I do think that this is going to remember this slide for when I come to show you some of the T-cell engaging data where this doesn't remain true. And that's quite exciting, I think. So normally the PFS after your first line therapy gets shorter after your second line therapy and shorter again after your third line. Now, let me just move that. There we go. So I think that there are three important clinical decisions when we're thinking about our relapsed refractory patients. The first one is, how should we treat early relapse? Secondly, thinking about second and third line treatment options. And then excitingly, where these T-cell engagers are going to fit in and what are the data behind CAR-T and bispecs in the follicular lymphoma pathway. Now, the reason why there is so much difficulty in preparing patients for follicular lymphoma is that there's no clear pathway. And you can see here from the ESMO guidance that your first line options, you've got different options. Your second line options will depend both on disease performance, so how long they've had a response for, how fit the patient is, but it will also depend on what option you chose first line. So it's really different from large cell lymphoma where you have a fixed option, first line, second line, and carrying on down. So this is really important in terms of where we're thinking of our treatment options. But something that I do think we mustn't forget is that when a patient remains in a CR 30 months after their first chemoimmunotherapy, their survival matches the same age-sex match population. And I think that that's really important because it comes back to that communication with the patients. Because yes, some people will do badly with follicular lymphoma, and sadly, some people will die from follicular lymphoma. But there are a significant number of patients out there who have a normal life expectancy after chemoimmunotherapy, or even 30% that never ever need any treatment, who we could have potentially ruined their lives because they have a cancer diagnosis and we haven't carefully explained to them that it might be that they die of something else that is nothing to do either with their follicular lymphoma or their treatment for their follicular lymphoma. And so this is certainly something that I think is really important that we discuss with our patients, especially telling the good news as well as the bad news. However, the bad news group for me are these early relapsing patients. And these are the patients that we need to do more research in. These are the patients that we really need to understand the biology in because they have a poor outcome. And the POD24, progression of disease within 24 months, you can see have an inferior overall survival. And interestingly, a significant number of patients who relapse within 24 months from their first-line chemoimmunotherapy have transformed to a high-grade lymphoma. So it's really important that we're biopsying these people, because then we can move them onto the high-grade pathway. And certainly in the UK, we have a lot more treatment options reimbursed for high-grade lymphoma than we do for follicular lymphoma. And the treatment options are so different that we want to make sure we truly know if they've transformed or not. So the more and more lymphoma that I do, the more and more biopsies that I do for my patients, because I've seen unusual things happen across all subtypes of lymphoma, but the POD24 patients definitely need a biopsy. So thinking about biopsy, if they've relapsed, thinking about whether they need treatment. Now, most POD24s are aggressive, and I think that they do need treatment. But occasionally, if patients, particularly if they've relapsed a bit later, you can watch them a bit more. And then coming back to the patient factors, the goals of the patient, and bringing the patient into all of our decisions. So when I have a patient who's relapsed early, I have to say that I take them, or I try and take them to autologous stem cell transplant. And there are these data from the US showing it's retrospective data, but patients who had an auto had a survival benefit from those who did not have an auto. And there's prospective data showing a similar outcome. So if I have a patient who has relapsed within 2 years, I tend to give them different R chemo. So for example, if I've given them Bender to start with, I may give them CHOP second line. And if they get a good response, I then take them to auto. And this is certainly our current approach in the UK for the fit patients who have an early relapse. Now, as I'm going to come on and talk about, there are more and more treatment options available in terms of T-cell engagers, which have less toxicity than autologous stem cell transplant. And certainly in countries where they have reimbursement of CAR-T or bispecs, third or fourth line for follicular lymphoma, they are now doing fewer second-line autos. Auto, I think, also has a place third line, fourth line and beyond, because but the data are certainly there that the earlier you do the auto, the better the difference in outcome. So I use it for early treatment failure. Now, what about allogeneic transplant? Now, graft versus lymphoma effect in follicular lymphoma is very effective, a bit like in Hodgkin lymphoma. But because of these data, an example here, a 2-year NRM of 27%, I really don't do many allos on my patients with follicular anymore. So like Hodgkin, where I save it for 5th, 6th line as late as possible, I try and use all of our chemo or antibody approaches. For follicular lymphoma, I do occasionally think about it in a 3rd, 4th line setting, but I would certainly be looking for a clinical trial using a bispec or CAR-T before doing an allo because of the treatment-related mortality associated with it. If a patient doesn't die from the procedure, actually the lymphoma effect is still very effective. So what about 2nd and 3rd line treatment? So we've talked about R² in a 1st line setting. The Augment study looked at patients with relapsed patients. It actually excluded rituximab refractory patients. And in the Augment study, they treated patients with follicular or marginal zone lymphoma who were not rituximab refractory. And they randomized them to R² to R placebo. Now, I think many of us would argue that rituximab isn't a standard of care for in a relapse setting as a single agent. So I don't think that the so-called standard arm is a true standard. And I think that that certainly makes me consider this data very carefully. But I think when we look at the outcomes from the R² arm, it is a good outcome for the majority of patients. It isn't without toxicity. You can look at the infection rates of R squared compared to single agent rituximab, and you can look at the neutropenia. So this phrase, chemo-free, is not toxicity-free. There was a median progression-free survival of 39 months in the R squared arm. And I think that with longer follow-up, there's also a survival benefit. But remember, that's comparing it to single agent rituximab. So not a fair comparison, but R squared in itself is effective. We've also got the ongoing MAGNIFY study, which is looking at R squared induction followed by R squared versus rituximab maintenance. And this again is including follicular lymphoma and marginal zone lymphoma. And you can see here that this does include rituximab refractory patients. So we've only got some interim responses from this, but actually, again, I think it gives you the idea that actually this is an effective option for patients with quite impressive CR rates and the duration of response not reached. And in the rituximab refractory group, a PFS, a median PFS of 27 months. So I do think that R squared in a relapsed setting can be effective, and it's got a licensed second line and beyond for patients. PI3 kinase inhibitors have now been withdrawn, and I was going to take this slide out completely. The reason I didn't is that there are ongoing studies using different intermittent dosing, more selective PI3 kinase inhibitors, and maybe by using these drugs more carefully with better infection prophylaxis, there may be a role in the future, but at the moment, PI3 kinase inhibitors are not an approach that I use. And then the other option is that we have tazemetostat, which is an EZH2 inhibitor. And this is available and licensed third line and beyond. And I think that what was interesting from the tazemetostat data was that there was efficacy not only in the mutated cohort, but also in the wild type cohort. And so this has in a licensed third line and beyond, it is well-tolerated oral treatment. This is going through NICE, but it's not reimbursed in the UK yet. I am hoping that we will have access to this. So when we think about second and third line treatment for our patients with relapsed lymphoma, the first thing I want to know is, have they had an early relapse? And if it's early, I give them more chemo and I get them to auto if they're fit enough. If it's beyond 2 years, and remember I biopsy everybody, then I think our options are R squared, more R chemo, third line and beyond, tazemetostat. In the UK, so as you know, I'm quite involved in our British Society for Haematology, and we looked throughout the UK how people are sequencing and when they're using R squared. And it's interesting that many centres are still using more R chemo, second line, and saving R squared, third line and beyond. And I think that really there's pros and cons again of each approach. So for my older, less fit patients, I tend to move to R squared second line. But for some of my younger, more fit patients, I'm giving them more R chemo and then saving R squared later line. And then if I can't get access to T-cell engagers, which I'm going to come on and talk to, that's when we're thinking, if we've used all our options, there's no trial options, do we have to think about allo? So just finally on this section, I want to think about T-cell engagers, because I think you all know about my love of the T-cell. I think that the T-cell is revolutionizing our treatment for patients with lymphoma. And this is a summary of the bispecific antibodies and CAR-T antibodies, both in development with some of a summary of their data. And we have 3 licensed T-cell engagers. Mosun, which is a bispecific antibody, which is for patients third line and beyond. Axicell and Tyzacell are CAR-Ts, and they have Axicell as a slightly different license depending on the FDA license, which is third line and beyond, and the European license, which is 4th line and beyond, and Tizacel, which is 3rd line and beyond. Now, it's really interesting because these data for all 3 of these T-cell engagers, in my opinion, is really impressive. However, NICE in the UK have said no to reimbursement for these. So I've only used these in a clinical trial setting. And the reason being is coming back to that point about heterogeneity of pathways, heterogeneity of predicted outcomes for patients. And therefore, it was very difficult to show cost-effective analysis on a predicted outcome for a patient with low-grade lymphoma. Unlike large cell lymphoma, where we've got glofitamab NICE approved now, and we've got CAR-T, 2nd line, 3rd line, if a patient relapses, they usually die in a short number of months. It is more varied for patients with follicular lymphoma, and therefore it did not meet the economic analysis required for NICE, which is frustrating, and we are still going on to try and get some of this reimbursed for our patients. So when we're thinking about bispecific antibodies, they've got 2 arms. The CD3 sticks to the patient's T cell, the CD20 to the patient's lymphoma B cell, and brings them together, activates the T cell, release of cytokines, and causes cell death. And because of that release of cytokines, we do see cytokine release syndrome, similarly to how we see in CAR-T and other T-cell effector mechanisms. However, it's usually predictable and low grade, and bispecific antibodies, in my opinion, are a lot more easy to deliver compared to CAR-T treatment. The CRS is mitigated by giving step-up dosing, so small doses to start with. And in a clinical trial setting, which is when I've used Mosun, I've seen very little CRS by giving good pre-med and this step-up dosing. And certainly we've been able to deliver this in an outpatient setting for low-grade lymphoma. And these are a high-risk group of patients. If you look, half of them are POD24s, 20% of them have had prior autos, and this is 4th line and beyond in the most patients. A really high risk group, and yet you're seeing this median PFS of 18 months with 60% obtaining complete response. And this is again coming back to the opposite of what we used to see, where each subsequent line was getting a shorter duration of response. With Mosun, it is flipped. So the prior therapy in the red showing their duration of response compared to Mosun. So we are seeing an improvement compared to prior lines. And as you would expect, if you get a CR, the responses appear to be durable. So a high-risk group of patients, heavily pre-treated, with a really high response rate for such a risk group. And you don't see much grade 3 for CRS, only 2%. So remember, grade 1 and 2 are managed on the ward. Grade 1 is observed. Grade 2, you give some tocilizumab and an anti-IL-6. So it's only grade 3 that needs support from ITU with inotrope. And the numbers of that were very small. When we think about Axicel, the ZUMA-5 study, a similar high-risk group of patients. So again, they were treated at least 2 prior lines of treatment. And again, you can see over half of the patients were POD24s. So here, if you look here, in this study, they also included patients with marginal zone lymphoma. But if we focus in on the middle section of this bar chart, 80% of patients obtained a complete response, which again, such heavily pretreated patients, I think is really impressive. And a 12-month progression-free survival rate of 78%. So yes, we do have to be aware of any CRS, and we do have to be monitoring carefully for CRS. And we're also, with CAR-Ts, unlike bispecifics, seeing neurological toxicity. So CAR-Ts do have to be delivered in a CAR-T center, unlike bispecs, which can be delivered in any hospital where you can manage neutropenic sepsis. So this is the more updated data from ASH last year, again showing in the blue the PFS curves for the follicular patients and the OS curves. So again, bearing in mind that many of these patients are fourth line and beyond, I think that these are impressive. So I always think it's quite difficult, but they do like to compare back to retrospective data. So the Scholar-5 data was retrospective, one historical clinical trial. And you can see here, again, doing this propensity score weighting, that when they propensity score matched Zuma-5 to Scholar-5, they had just over 80 patients. And there was an improvement comparing it to that retrospective data in Zuma-5 compared to Scholar-5. And there's further long-term follow-up with a median progression-free survival of 40 months. So I don't think there's any doubt in efficacy of T-cell engagers in this high-risk population. And just to finish off about Tizacel, so this is third line and beyond license. Again, the Alara study with CAR-T, I mean, it's so effective. It is more difficult to deliver than a bispecific off the shelf. But I think, again, many CAR-T centers, we've gained so much experience from high-grade disease about trying to get patients quick apheresis slots, bridging, and then quick reinfusion. But you again see that these are a median of 4 prior lines of therapy, and a third of patients nearly had 5 or more prior lines of therapy. So these were not selected good risk patients. The Alara data would suggest that Tizacel had less toxicity compared to Axicel, and still an impressive CR rate of 66%. So different patient populations, maybe a slightly lower CR rate, but certainly an easier drug to give in terms of toxicity. The 6-month progression-free survival rate was 76%. And you can see here that with extended follow-up, the median PFS of 30 months. If patients obtained a CR, which is as we would expect, the PFS was more durable compared to those patients in a PR. And you can see in the orange line, that's all the patients. So like all of our patients who have a cellular therapy or bispec, the durability, as we would expect, is better if people get a CR. So a high-risk group of patients. And really the side effects that we need to be aware of, and I think as T-cell engagers are becoming more and more common, CRS and ICANS, certainly CRS for bispecs, needs to be understood. And I'm also mindful of tumor flare, because initially when we give these agents, you certainly see increased activity on PET imaging, but I've seen patients present with increase in size of their adenopathy, and you think, oh, clinically they've got a progression event, and then a week later they've gone into a CR. So we've got to be mindful that not all progressions, when somebody has got a T-cell engager, it could actually be tumor flare. So I'm certainly now speaking to all of my colleagues in our region and throughout England and Scotland about cytokine release, because I want access to bispecifics to be more equitable for patients rather than just being in CAR-T centers. And for CRS, it's difficult to distinguish from sepsis. And in practice, I've just finished a week in tending. In practice, I treat both. So if they meet the criteria of grading of CRS needing treatment, I treat that. But they all have fever by definition of CRS. And so I would cover them with broad spectrum antibiotics as well. So this is the chart that we've got on all of our walls in our hospitals where we're looking after patients on bispec. And essentially, if they've only got a temperature, they're grade 1 and I do nothing. If they've got a temperature and they drop their blood pressure but don't need inotropic support, and we just give them a little bit of fluid, then they're grade 2, or if they need a little bit of oxygen. And at that point is when I give them some tocilizumab. So that's 8 milligrams per kilogram intravenously. And most patients switch off their CRS with 1 dose. Occasionally, I have to give 2 doses. And if you're treating at grade 2, it is very, very rare to then go to grade 3, in which case you need ITU support. So for the majority of patients, it's grade 1. You don't need to do anything. If they've got grade 1 for 3 days, I sometimes give them a dose of toci. But as soon as they've got grade 2, then I would do that. And it's very predictable for bispecs, and it's usually with only the first sort of dose that they see it. ICANS is rare with bispecifics. However, we do see it with CAR-T, and that's why CAR-T has to be monitored more closely. Patients have to have someone with them for the first month because it can be quite subtle, their neurological deterioration. And when they have it and they reach grade 2, then I give them Dex 10 milligrams QDS. And again, by doing that, as soon as they hit grade 2, it's very rare for people to need any support from the intensive care unit. So I'm hoping, and I'm really excited by bispecifics come into practice. We've got them licensed in the UK, reimbursed for large cell lymphoma. They've got license for follicular lymphoma, and we are fighting hard to get reimbursement, and they're being used in a private practice setting already in the UK. But we have these treatment options available, but there isn't a clear sequencing because it really depends on individual patient factors as well as disease factors, which vary so much more than they do for large cell lymphoma. So personalizing treatment is important. Understanding the biology is important, and I'm hoping the future will be risk-adapted treatment decisions, understanding more before we start, and really hopefully understanding optimal sequencing. And I think that we may get T-cell engagers higher up the treatment pathway in the future to try and reduce the toxicity we expose our patients to with chemoimmunotherapy. And I'm going to stop sharing now before I finish off on the collaborative discussion. So,
yeah, are there questions? I think we have used very little of this, but if there's anybody who has experience, would be good to know. I suppose in clinical trials, we will soon start using some of these agents, not the ones you discussed. Oh, Zinat, that's great. Let's hear from you.
Hi, Estelle and Wendy. I'm just finding out about the bispecifics after using bendamustine. So I have a patient who had R-CHOP and R-GDP and RB, and then moved on to the bispecifics. And she developed massive mediastinal nodes, so massive that it actually looked like cannonball lesions from a lung CA. And she was rebiopsied, and it showed follicular lymphoma. And now she's actually needing to take the bispecific with R². So I just wanted to find out about bendamustine as an upfront treatment in patients who eventually might need the bispecifics.
Yeah, and I think that is the million-dollar question, because we know that bendamustine causes T-cell depletion, and we know that certainly from the data from Gloria Iacoboni that if patients have bendamustine within 9 months of their CAR T cells for high-grade lymphoma, that it impacts on efficacy of those CAR Ts, and it makes biological sense. And we are avoiding bendamustine now in large cell lymphoma before we are giving them the 2 approved Axicel or glofitamab. It makes sense, and there's some data coming out that if you give bendamustine, it may also reduce the efficacy of T-cell engagers in follicular. And what we're seeing the same with mantle cell as well. And therefore, we are trying to think and predict the timing of when patients are going to need their T-cell engagers, because it appears to be that longer than 9 months isn't having such an impact. So has it stopped me using bendamustine first line for my patients with follicular? It hasn't at the moment, partly because, as I've said, T-cell engagers aren't reimbursed for me, because I don't do private practice. But also, it does give a long time to next treatment. And the data for Benda from that STILL study is really impressive. And it would be unlikely that they would get through second line, third line, and to that fourth line bispec within 9 months where we've seen the data in large cell. However, for patients, for example, with mantle cell, when they're presenting with blastoid P53, and I think they're going to get to third line CAR T very quickly, I've now stopped using Benda as my first line. So I'm now often using CHOP first line, ibrutinib second line, because I think that sadly that access to brexacaptogene third line is going to be quick. So your patient is interesting, because you talk, one of the studies that we've had open is Mosen with lenalidomide, and you've talked and rituximab. So the data Mosen in combination with len, it's not licensed yet, but on a clinical trial data, it does look really encouraging. So do I worry about bendamustine? Yes. Do I change my pathways because of the knowledge? Certainly do for large cells, certainly have done for some mantle patients. For follicular, not at the moment because of what I've got access to. And also I think that the time scale appears to be longer than that critical 9 months. Does that answer your question?
Yes, it does, Wendy. The next thing is, what would make obinutuzumab better than the rituximab? You know, when would you consider using that?
Yeah.
When you're using a bispecific, yeah.
So I can only, so the data for obinutuzumab is only in a first line setting and from the gallium data. So in a first line setting, I talk to my patients about the fact that if we want to have the longer time to next treatment, obinutuzumab clearly shows that in gallium. But there are more infections, not many, but there are more infections and infusion-related reactions. So I talk to them about that. And then the other difference is that we are able to give maintenance subcutaneously for 2 years with rituximab. But if we're giving obinutuzumab, it still has to be intravenously because of the license. So again, I talk to my patients. There are some people that are still, you know, at work, and it takes longer to give, have to get a cannula in. And for some people, they say, I want the subcut maintenance and I don't want the infusion-related reactions. I've got other people who say, I want the longest time to next treatment now because this is really important to me at this point in my life. And I don't mind having my cannula every 2 months. I would rather have that. So I talk to my patients about both, but only in a first line setting. In a relapsed refractory setting, we in the UK are only allowed to give it when it's in combination with bendamustine, so O-Benda, and that was from the Gadolin study. And I would use this if in the very rare patients. So with the Gadolin study, which was patients who were rituximab refractory, so those early relapses, they had a survival benefit when they got O-Benda in a second-line rituximab refractory setting in the Gadolin study. But the reason I don't do that is because I have usually given Benda first line because of the data showing it's got a longer response, or I've given obinutuzumab first line because of the gallium data. But if, for example, I had a patient who had RCVP first line, had an early relapse, were not fit for auto, then I would use O-Benda because of that Gadolin data.
Okay. Thank you.
And I've just seen that there's a question in the chat about iodine 131 and anti-CD20 antibody. So we don't have that reimbursed. So I don't have any standard experience with that. And I think that there's going to be so much, I think that because there is so much impressive data from the bispecific antibodies, certainly the focus of where the resource is going into research in the UK, it's focusing on that. So I'm aware that we've just got 10 minutes or so left. So, and I don't want to miss the important part about collaboration. So I wondered if I could just finish on that, if that's okay.
Absolutely. If it's, yeah, just, that'll be great.
And really, I've got a couple of slides, and then I'm just going to stop sharing and just hear what everyone's thoughts are about this, because essentially the collaboration that we do in the UK, there is some really positive parts of it, and essentially we have 5 collaborative lymphoma groups. The biggest group is the high-grade lymphoma group, because obviously it feels like it's huge in terms of what we are trying to cover, and we have separate working groups of CNS, T-cell and elderly, and then the overarching sort of effectively the B-cell high-grade group. And within that group, we are sort of designing academic studies, designing academic data collaborations, and working together to make sure that we agree with the ethics and design of our UK academic studies. So we've got the high-grade lymphoma group, we've got a similar low-grade lymphoma group, and then we've got this lymphoma science group, which works across all of the subgroups, because it's really important that our translational data is clinically useful. So how we do it is our sort of 3 lymphoma groups, high grade, low grade, and Hodgkin. We used to meet face-to-face. Now, since the pandemic and since funding issues, which I'm going to come and talk about, we meet 3 times a year on a Teams call, on a virtual call. But then overarching and linking with those 3 main groups, we've got our science subgroup, and then our real world data group, because we're understanding that as so much is coming to patient selection and sequencing, that the only way we're going to get that data is from real world data. And because we are one national health service, we have actually got the data that we can access to understand patient outcomes. So we make sure that within this, and we're very open, so anybody can join, and that's certainly easier now that we are virtual, because we used to have to try and work out sort of funding for travel expenses. But we are making sure that we not only are geographical representation, but we are cross specialty. So we will make sure that we have radiologists and histopathologists and pediatric lymphoma and adult lymphoma and statisticians. And this, we also do quite a lot of collaboration with international group. And I think that there's a lot of strengths that we've got in the UK, but one of them being that we have to have similar pathways, and we've certainly got similar funding rules because of the NHS and NICE agreement. But the challenges have certainly been getting funding from a lot of our academic studies, because we want to ask quite a lot of chemo questions. So an example of one of our studies would be RATHL, and that the RATHL question was, can we drop bleomycin after 2 cycles of ABVD? And that has been practice changing. But now our funding, which did come or does come from Cancer Research UK or Bloodwise, which used to be the Leukemia Research Foundation, funding has become more challenging, and we get limited government input. So there is some money comes in from the government, but most of it relies from charity funding and from pharmaceutical funding. And therefore, chemo questions are unlikely to get funded, because often, certainly industry funding is wanting to look at efficacy of new drugs. And for if we're trying to go to CRUK for funding, they have certain areas where they have targets that they want to meet. So whether it's teenage, young adult, or there's certain criteria that they have to meet, unmet needs. So, we all wanted to do a RATHL versus HD18 trial, but we couldn't get funding for that because it was chemo versus chemo. So that's a problem. And there's also difficulties with setting up sites. The pandemic set everything back. It feels like 5 years. we've also always had the NCRI, which is the National Cancer Research Institute, and the government funded that 22 years ago. And it wasn't a huge amount of money, but it allowed for us to meet, it allowed for us to have our statistician funding, a little bit of administrative support. And unfortunately, I think it was 8 months ago now, that money's been pulled. Don't get me onto politics, that would be very dull for you, but that is very frustrating. But we are now left with a strong wish of UK clinicians and academics. We all want to work together because we know that we're all useless individually, but together we're a pretty strong, impressive unit because we've got fantastic scientists doing translational work. We've got brilliant statisticians. Our pet radiologists are fantastic. So we want this to continue. So we have now set up our UK lymphoma group, and the fact that we're one NHS is something that's certainly in our favour. So the logo has, I have to admit, my husband's helped design this, but this is our not confirmed new logo, but it's the same people, but we are going to have to get some funding for administrative support to continue with our work. Now, I'm going to stop sharing now because I can already see there's a question, but essentially we have still got agreement for, first-line elderly Hodgkin study that's ratified, that's about to open soon. That's an UK academic study, and we're hoping our first-line large-cell lymphoma study. We're just waiting for the final contracts to be signed. So we have got a lot of that money comes from split grants from Cancer Research UK and pharmaceutical company, depending if we're using a novel drug or not. But we're also going to need our own funding for administrative support, just for the meetings we have and the minutes, and not a huge amount of funding from that. But I think that we feel really strongly that the benefit of us working together, you'll have seen our collaborative CAR-T data that Andrea Kuhnel's published. I mean, that was from us just collecting our own data and collaboratively working together to get it published. So a lot of it is working in our own time. A lot of it is, if it's a trial, it's got proper funding from those resources I've said. But I'm hoping that in the future we'll work in a way. I mean, if you look at the French, they have a good collaborative funding, and they get a lot of their funding again from pharma input, but also sort of nationally funded. Because I do think that if we want to improve academic outputs, we definitely need to work together.
Well, that was an absolutely great inspiration. I don't know if there's remarks from my colleagues.
So I can see there's one question there. So who coordinates and arranges the group meetings and grant? Yeah. So you've asked me about this, Estelle, at a real time of flux, because when we had our NCRI, they did put in some administrative support, but I have to say it did come from the clinicians. And we have a chair of the high grade subgroup, we've got 5 chairs, and they are the ones that, it sounds pretty basic, but would literally send, okay, these are the 4 dates for the meetings for 2024. We would have the afternoon or 2 hours or however long it's going to be. And, the minutes would be fine. They wouldn't be the most detailed minutes, but what happens then is that we are dividing up in a group. And, for example, for the last trial, I was in charge of the PPI, so the patient partnership involvement, because that's a massive important part to put forward to grant funding studies, and would do that section. And we would be dividing it up, dividing and conquering, and then bring the whole application together with some support from the CTU. So the clinical trials units, we have several in the country, and we work with different CTUs for different studies, and they're all fantastic. So the actual grant application would be written alongside employees of the CTU, and the costing for that CTU would be included within the grant application. So there would be a bit of lost leader in terms of, if you don't get the grant, that work has been done effectively for nothing. But then there would be, you know, we know that we will be getting some work through that CTU.
That's very practical, and I think doable. And yeah, we hope to be able to start in a small scale, and you know, start with 1 or 2 low-hanging fruits. Let's see what we can do. But we'll know where to ask for advice. We'll know where to go. Sounds great, and lots of dedication. Very, very impressive that you can do that. I think it's time for me to say a very good end of year to everybody who was here. Thank you to Roche for bringing Wendy again. We are so impressed, so thankful. Such real world and real practical advice. Thank you very much, and I wish everybody a wonderful end of year, and see you again in 2024. So
Thank you very much, and enjoy your lovely summer.
We'll do
And
that.
think of me as I go into the dark, wet winter in England.
You know where to come. You know where to
Yes.
come for some sun.
Lovely, and
just a
lovely
fossil,
to see.
just a fossil fuel flight away.
I know.
Okay, everybody. Good afternoon. Thank you, Wendy.
That's a pleasure. Bye bye.